Good morning, good afternoon. My name is Ryan Judd. I'm the clinical director at the OCD Institute of Texas. I'm very excited to welcome you all here today to another one of our installments in our new webinar series for families and loved ones of people suffering from OCD and anxiety disorders. This is in session with the Institute. I'm joined here today with two of our incredible clinicians, Dr. Callie Warner and Victoria Lane, who are experts and have many years of experience working with individuals with OCD and anxiety, and also, very importantly, their family members, parents, spouses, and adult children sometimes. And we have a great topic for you today. We are talking all about supporting a loved one with OCD, specifically understanding ERP and family involvement in that process. So it can be kind of confusing from the outside if you're not a mental health professional, but we're going to try to, Callie and Victoria are going to demystify the process for you. Our goal is that you walk away at the end of today with a really clear, thorough understanding of what ERP is, what it's going to look like for your loved one, and your role in that process. So I'm going to turn it over to our fabulous clinicians here and let you guys take it away.
Thanks, Ryan.
Thank you.
All right, just as a reminder, as we start to dive into these slides, if you guys have questions for us, remember we do save quite a bit of time at the end, so please submit those as we're going through these, and we will be answering your questions live. Supporting a loved one with OCD and understanding ERP and family involvement. Last time we were on, we discussed a lot of different scenarios where family accommodations take place. And so today we're going to do a little bit of a deeper dive into that. What is OCD? We know that it includes the presence of obsessions, compulsions, or both. Usually, typically, we find that the presence of obsessions and compulsions are both present. We just often find that compulsions can be hidden, right? So mentally reviewing, if your child is worried about hurting someone's feelings and they say to you, I think that I had a conversation with a friend and I think I might have hurt their feelings. From the outside, that might just look like they are obsessing, ruminating about something, but internally they might be replaying that conversation over and over in their head, which actually is resulting in a compulsion additionally. The obsessions or compulsions are time consuming. And so we know that if I were to pull up the DSM or the Yale-Brown Obsessive-compulsive scale and the symptom checklist, many of us would tend to check one or two of those symptoms on that symptom checklist. But reality is that if we're not taking at least an hour out of our day to engage in these compulsions, we're probably not meeting diagnostic criteria. It does need to impact areas of functioning socially or just at the work life or at home life as well. And then additionally, is it not better explained by another diagnosis? And so oftentimes I use the example of autism. There's stemming behaviors involved in autism. Someone might be engaging in a stemming behavior to regulate themselves. They might be rocking back and forth or tapping a surface. The purpose of that behavior is very different than if they're engaging in that behavior for an OCD reason, right? If they're doing that behavior because they feel like something bad will happen if they don't tap that surface. And so we're really trying to dive into what's the function of that behavior.
Absolutely. So I think one of the big things that I want us to start with when we talk about, well, what is ERP, right, is what is an obsession and what is a compulsion and how does treatment fit into that, right? So we'll start first with an obsession, like Callie was saying, is OCD involves these obsessions and compulsions, right? These obsessions are these unwanted, recurrent, intrusive thoughts, images, feelings, urges, whatever it might be, right, that are unwanted to the individual. And they cause a lot of anxiety or distress or discomfort, right? So naturally, our mind would say, I don't want to face those things, right? I don't want to be approaching those fears. I don't want to be approaching intrusive thoughts that I don't want to have, right? So when we talk about ERP is exposure and response prevention therapy. This is the gold standard treatment for OCD. Our first step is this exposure piece, right? This involves facing our fear. And then our next step of this process is the response prevention piece, where this is really focused on the compulsive behaviors, right? These compulsive behaviors are these unwanted, right? Whether they're behavioral or mental acts that are done in an attempt to reduce the anxiety that those obsessions cause, or maybe even like try and prevent that feared outcome from happening or to get rid of those thoughts or whatever that might be. So when we look at this response prevention piece, we're actually starting to eliminate those unhelpful responses that keep the cycle going. So ultimately, as we'll talk about a little bit more about kind of incorporating family into treatment and what that looks like, is we're going to talk a lot about what family accommodations are. And family accommodations actually play the same role as compulsions in the OCD cycle, right? So when we go back to exposure and response prevention, we really want to break it down a little bit. We want to start with facing our fear, and then we want to start with eliminating those unhelpful responses. So some examples, we have a whole bunch of examples on the screen, but I'll kind of point out a few of them is maybe we have some contamination OCD where we have a fear of developing an illness from touching a doorknob. So an example of an exposure would be to touch that contaminated doorknob. And then that response prevention would be to cross-contaminate those safe spaces that we have. Because a lot of individuals with OCD, with contamination OCD, will have those safe spaces where they'll want to keep clean, everything's perfect, right? There's no like triggers in there. So we'll want to cross-contaminate that. We'll also probably want to eliminate those compulsive hand washes, right? Maybe we're eliminating compulsive showering, right? Whatever that might be, whatever an individual does to try and alleviate that anxiety, we're going to start reducing, right? Maybe the individual has some harm intrusive thoughts, right? So an exposure would be to hold a knife, right? And our response prevention is going to be with a firm grip, right? We're appearing confident. We have that calm body. We're not this like tensed up holding the knife, like, oh, I don't want to hold this. I don't want to hold this, right? We're allowing ourselves to say, yeah, we're holding a knife. Maybe we're cutting some vegetables. Maybe we're cutting a birthday cake, right? And engaging in those values-based activities. So really, ultimately, what we want to be thinking about is what's triggering our anxiety, what's triggering discomfort. Can we start to face those things? And can we start to slowly reduce the things that we do, whether it's behaviorally or mentally, right, that try and alleviate that anxiety, that try and prevent that feared outcome from happening and actually allow ourselves to experience anxiety?
So we need to also understand the ERP cycle. And I love graphs, images. And so I feel like this really just ties everything Victoria was saying together about good response prevention. But first, let's dive into what the OCD cycle looks like. So we might have this trigger of someone holding the knife and the anxiety goes up. And so they immediately put the knife down. Well, great. They feel better temporarily, right? But then the next time they pick up that knife, the anxiety goes right back up. And so that's where we see that triangle of the cycle coming into play. When we're asking a patient to do an exposure, or we're asking a family member to not answer that reassurance question when their kid says, do you think I would actually harm somebody when I'm cutting this apple? We're really asking the kid to lean in more. And the first time they do that, they might experience even more anxiety, right? But we know that the human brain can't stay that anxious forever, especially if we're re-engaging with the day or the things that we need to engage in instead of playing with that thought. And so that anxiety does start to go down all on its own without having done the compulsion. So they repeat that exposure or they do other variations of that exposure of, you know what, I'm going to hold the knife and I'm going to cut 2 pieces of fruit, or I'm going to hold the knife and I'm not going to ask mom for any reassurance around if she was next to me in the kitchen when I did that, or if she thinks that I would do something bad, or if everything is going to be okay. And what they start to do is they send a message to the brain that, wow, I really can tolerate that distress of not knowing when my OCD said I couldn't, right? The big piece to having to navigate OCD is recognizing that I can handle and I can tolerate some of that uncertainty that my OCD says I can't, that I have to have 100% certainty around. And the problem with that is we don't ever get 100% certainty, right? Mom answers that question and says, you know, you would never actually hurt someone with a knife. And at first they feel better, right? That gives them this, I always say, false perception of certainty that I in fact won't do that. But OCD bullies them and comes right back around and says, but what if you would? And we get back into that uncertainty loop. And so we're kind of, what I say when we're doing exposure work is beating OCD to the punch. We're going straight to the uncertainty place and we're teaching ourselves that I can live a happy, comfortable life here.
Absolutely, right? So now we're going to get into what is this family accommodations word that a lot of us have been talking about, right? So first, before I get into what are family accommodations, I really want us to talk a little bit about the importance of family involvement in treatment, right? As well as how OCD kind of loops in the family. Right. So whether you are a parent, a loved one, a caregiver, when your loved one has OCD, right, and is displaying these OCD symptoms, a lot of times this is affecting the entire family system, right? It's not just affecting the individual that is experiencing the symptoms. So we actually have a word for this, right? And it's called family accommodations. Family accommodations occur when loved ones change their behavior to help a person avoid anxiety or distress related to OCD. Now, we'll get into what examples are and why we do this, but these behaviors are well-intentioned, right? We think that we're doing this to help our loved one. We think we're doing this to relieve their anxiety. But ultimately, they often strengthen OCD over time, right? So, some common examples of family accommodations can be reassuring your loved one, right? What can this look like? Okay, maybe your loved one with OCD is coming to you and saying, like, Mom, am I going to be okay? I ate that fruit, but I think it might be expired. And you respond, Yeah, sweetie, you're going to be great. Everything's okay. Like, that fruit is safe, right? Maybe you're cleaning for a loved one. So, this can involve, okay, maybe someone that has contamination OCD is coming in from playing outside and they feel really dirty and contaminated and they go upstairs to take a shower, but then you're spending the entire time there in the shower kind of cleaning every single area where that individual walked to make sure everything's clean and ready for them to come out of the shower so they don't feel contaminated. Another common example of family accommodations are avoiding triggers for loved ones, right? This is a huge one, and this is probably one of the biggest ones that we see, is because ultimately family members are afraid of triggering someone, right? Because A, we don't want our loved ones to experience anxiety. We don't want them to go through that pain and feel like that torture that is within them, right? So maybe we're just going to avoid all those triggers altogether. Maybe we're going to avoid going to certain places that might trigger our loved one. Maybe we're going to avoid touching certain items, taking out the trash, whatever that might look like, right? But really identifying what are some of the main triggers and how can we start avoiding them. Some other examples are modifying your family routines around OCD, right? This can look like, oh, well, I really want to go to that baseball game on Friday, but my loved one's really afraid that if I go to this game, then I'm going to come home contaminated and I'm going to contaminate the entire house. Okay, so I'm not going to go to the game, right? Or maybe they have a party to go to and there's a lot of intrusive thoughts around being at this party and what that might entail. Okay, so we're not going to go, the family's not going to go to the party, right? So we're modifying our normal day-to-day routines, the things that family members would like to be doing around our loved one's OCD. All right, and the last one we have here is participating in checking behaviors, right? This can look like maybe going around the house at night, checking all the locks with our loved one to make sure that they're locked, or even this can involve reassuring your loved one that everything's locked and everything's okay. Or maybe we're answering the same question over and over again, right? So these are all some examples of how family members are kind of getting pulled into OCD, right? Because why do we do this? Well, it reduces immediate distress, right? It avoids outbursts. It protects our loved ones from anxiety. And we ultimately feel guilty saying no, right? This is why we do these behaviors, is because we don't want to see our loved one in distress. We don't want to see them feel anxious. We don't want to see them be engaging in these compulsive behaviors that take up a lot of their day. So we're going to do whatever we possibly can to jump in and help. But unfortunately, as we'll kind of see, and we'll get into what the family accommodation cycle looks like, is that actually just sends the message to your loved one's brain that they can't handle this on their own and that they need someone to jump in and help.
Yeah, so a big reason why we want to support family members, as Victoria said, is because it's really hard, right? It's really hard to not give into that natural inclination to just make your child feel better in the moment, right? We feel guilty saying no. I really like emphasizing the importance of it's kind of nice to put some of that pressure on the therapist to give you the approval that it's okay to say no, right? And often we don't even know how much we should be saying no when we have someone from the outside the accommodation cycle circle, right? So I'm going to dive into what this circle looks like, but when someone's not really in it with you, they can often get to this place of, oh, I think it would probably be good to maybe only answer that question twice instead of 3 or 4 times like you have been doing. And it's assuring for you to hear that's the right way. That's how I'm going to get my loved one the freedom that they deserve and need. So what we see happen with this accommodation cycle, since we've already talked about the OCD cycle, is a trigger, right? A trigger comes into place. Maybe your adolescent gets stuck because they feel like they touched something that led to germs and they're going to get others sick. And so they have that trigger, that sticky thing that they touched, and now they feel anxiety. And their brain goes, I can't handle this anxiety. I've got to do something to feel better. Maybe your brain also goes, I don't love that my loved one is experiencing this or my kid is experiencing this. It's my job to protect them. And so I need to jump in and do what I can to make them feel better. And so you accommodate, right? So you say, hey, honey, it's okay. That sticky thing doesn't actually have the germs on it that you think it has, or that actually wouldn't get anybody sick, right? Whatever accommodation that kid is asking for at the time. And so you see this wave of relief come over them. They feel better. Maybe you feel better. And then what in turn happens though is the OCD grows stronger. And I think it's really important to note that the more that we're engaging in this behavior, the more accommodations this child adolescent might need. And often when we get really into this cycle, we've been doing it for a while, family can't even keep up with the accommodations anymore, right? It's not feasible. Maybe sibling isn't getting as much attention because we're spending so much time accommodating. Maybe it's that we are unable to get to bed at a decent time, and now this adolescent sleep cycle is disrupted because we're having to accommodate so much. And so when we scan out and we really look at the big picture, we know that these accommodations aren't going to be feasible long term. And so it's really important to just go ahead and be preventative with this while we can, so that we don't have to get to that place of complete debilitation as not only an individual struggling with OCD, but as a family system.
Absolutely, right? So this leads us directly into reducing accommodations, right? And this is where we are really going to kind of support, promote all of the above, is the importance of having a provider that you're working alongside with, right? So they're able to help guide you, they're able to help guide your child, your loved one, right? And really come up with a middle ground so it doesn't feel like this drastic thing that's changing, right? Ultimately, when we're talking about reducing accommodations, we're talking about this because we truly care about your loved one and we don't want to give OCD power, right? We're not doing this as torture. We're not doing this because we want your loved one to feel anxious, right? We're doing this because we don't want OCD to have power. So the treatment approach can vary in so many different ways, right? But really kind of the standard of what we want to be thinking about is we want to be sure that we're validating feelings without validating OCD. This can be extremely difficult, right? Because in the moment when OCD is very strong and all you hear from your loved one is OCD talking, right? It can be very, very difficult to validate that anxiety that the individual is experiencing, right? So we want to slow down and we want to say, okay, let's validate that. Let's say, like, yeah, this makes sense that you're really anxious right now, right? But we're not going to be validating what OCD says or what those OCD fears are, right? We want to encourage ERP type responses. What does this look like, right? This looks like removing those compulsive behaviors, right? Not giving into what the OCD wants, right? OCD wants that reassurance. OCD wants you to do something that makes you feel safe, right? And we're going to start promoting, we're actually not going to be doing those things, right? And we want to respond consistently. This is probably one of the most important pieces because if we don't respond consistently, the brain actually gets really confused and doesn't understand the message we're trying to send it, right? Because ultimately, we're trying to help your loved one's brain understand that they can handle this anxiety. Anxiety is not dangerous. We don't have to respond to OCD. And if we kind of responding consistently to that OCD, OCD is not going to learn, right? And it's not going to rewire the brain. And like we said, utilize provider support, right? If it's available to you as much as you possibly can, utilize their support to be able to walk you through the steps. Now, we'll kind of talk about it a little bit later about the like how family can get involved in treatment and what options there are, but there's a program, it's the shorthand is SPACE, right? It's Supportive Parenting for Anxious Childhood Emotions out of Yale with Dr. Ellie Leibowitz. And it really talks about kind of picking various targets, right? So what targets can we start with? We can start with maybe the accommodations that happen most frequently throughout the day with your child, right? And really develop a plan of how we're going to slowly reduce these accommodations. So maybe let's think about if maybe our loved one has some harm intrusive thoughts around knives. And right now we hide all nice, sharp objects in the kitchen. And whenever a child goes into the kitchen, we reassure them that, like, hey, it's okay, you're not going to touch anything, everything's going to be okay, you're going to make it out of here. Where can we start, right? Maybe we can start reincorporating knives at the dinner table, right? And have it on the table. Maybe we can start having mom use a knife to cut the vegetables and the child watch from afar, right? Like really kind of slowly reintroduce this idea of these triggers, right? So the child can start to learn that these are okay and we don't have to run away from it, just like OCD is telling us, right? So an example of we talked a lot about last time we were on this webinar around like supportive statements and what those look like, right? So validating and building confidence in your child's ability to tolerate that distress. So maybe a loved one struggling will ask you like, will eating this make me sick? And your probably natural response, right, is going to be, no, you definitely won't get sick. It's going to be okay. Now, what that's doing is that's feeding the OCD cycle, right? It's giving that short-term reassurance, but it's kind of continuing to feed in the long term. So an ERP approved response is actually going to be, I know you're anxious and I know you can do this, right? I am not going to answer this because I love you and not your OCD, right? That's super important is we're on the child's team, we're on your loved one's team, we're not on team OCD. Right. And when we're on the same team in this process of reducing accommodations, whether that be big accommodations, small accommodations, whatever it is, right, we're slowly starting to reduce anything you as a loved one are doing to try and alleviate your child's anxiety. We are on the individual's team, we're not on OCD's team, right? And that's super important because we don't want the child to feel like they're alone. We want the child to feel like we're in this with them, we're stronger than OCD, and we can fight this together because OCD doesn't have power on us.
And so some resources that we will probably go over again as these lovely questions start coming in. The accommodations, just a couple takeaways to remember, should be reduced at an appropriate pace, right? So I've had a loved one of an individual with OCD ask me before, well, they're really distressed by the washcloths in our kitchen, the cloths that we use to dry our dishes. And so I just the other day chased them around the house with the washcloth. And why wasn't that helpful? And in reality, we really need to keep in mind that this should never be a surprise for the individual and it should never be at a pace that's inappropriate, right? So kiddo didn't know that mom was going to chase them around with the washcloth. We're sending a bad message about ERP at that point. And the last thing we want to do is that because we really want them to look forward to at some point coming to therapy, know that it's going to be hard, but that it's giving them their life back. And so if we put that bad message in their brain from the start by chasing them around with the washcloth, they're probably never really going to want to come back. We also want to look for space-informed providers, as Victoria mentioned. You can go to the spacetreatment.net website and search for those providers by state, which is really nice and helpful. And oftentimes families will say, well, I think I can just do this on my own. But if you're struggling with some anxiety about your child's anxiety, I promise you it is just so helpful to get that extra support along the way from a provider saying you're doing a good job. And just giving you some helpful skills around what you should be changing or when we should be changing something. Because like I said, they're not in the cycle with you. They can see things a little bit more clearly. Sometimes doing your own work is necessary apart from space, right? So if you're finding it very difficult to let your child sit with some of that distress, that's often an indicator that it might be helpful for you to do some anxiety work around that. And sometimes parents will say, oh, but I don't want my kid to know that I struggle. There is not a better way to inspire your kid to do their own work if they see you doing the work. And so I really would just encourage that, getting some of your own work with anxiety and you guys being able to have open conversations about it. Of mom's therapist told her to do her homework today and she did it. And I'm so proud of myself for doing that, right? Imagine what kind of message that sends to your kid to do their own work. There's some additional resources that we've mentioned here. Going to iocdf.org, you can find OCD providers by state as well. Breaking Free from Child Anxiety and OCD is Dr. Ellie Lebowitz's book, and I think every parent should read it that's going through the OCD journey with their kids. When a family member has OCD, you really dive into the different OCD subtypes in this book, as with the Family Guide to Getting Over OCD by Dr. Jonathan Abramowitz. At this point, I think we're ready to dive into our live questions. Yeah.
Absolutely.
We'll start if we have questions from the audience. I also have a list of some of the most common questions that we get from parents and spouses and loved ones of people with OCD. So we'll get to some of those too. All right, we'll start with some of the questions from the attendees. So first question, how do you handle ERP when the person also has autism? Their sensory processing overwhelms them and adds to their contamination OCD. They are bedbound.
Well, I think I'll start and then you dive in, and maybe Ryan, I think you should probably dive in on this one too. But yeah, I think we really kind of go back to what is the function of some of these behaviors. If they're bedbound, you definitely need some more support, right? One of the things, I just want to start by addressing that first, because this is a very rich question, and I think we have 3 or 4 things to address in it. Someone that is bedbound usually is an indicator that they need a higher level of care. If your child is under the age of 18, also this kind of depends on the state. This is the one time in life where you can really get them into treatment, whether they really want to be doing that exposure work or not. And so I would do everything you can to encourage getting them into a higher level of care, because outpatient therapy once a week, 45 minutes is not going to cut it for someone that's avoiding all aspects of life, and you need additional support. The next piece I would say is, well, we know that when it comes to the OCD side of things, we're looking at what's the function of this behavior. Are they avoiding this because they're afraid that something bad will happen, because they're worried about the germ spreading, because they feel like they can't handle the anxiety that comes with it? We're taking more of that OCD approach. Are they overstimulated by the environment that they're in, or are they feeling just complete overwhelm because of all the things going on in their day? We might be taking an approach to kind of help them with some stemming behaviors to regulate a little bit more alongside while they're doing the exposure with response prevention. What else would you guys add?
Yeah, I mean, I think definitely echoing that, if someone is bedbound by their OCD, they definitely need intensive care and intensive treatment. It would be rare that they would kind of make a recovery otherwise. And so that's really important to get more information about what that would look like and how to make that happen for your loved one. I completely agree with what Callie's saying about, the sensory sensitivity or sensory processing challenges that are oftentimes a part of autism spectrum disorder, because we would approach those avoidant behaviors or those challenges or the distress created by that very differently than we would if it is the result of a pure obsession in OCD. So what you really want to look for, if you don't have already, is a really skilled therapist who's trained both in working with autism and OCD, because they're going to want to get a really thorough assessment to be able to very clearly parse apart what are the behaviors coming from autism and what are the behaviors coming from OCD, because the approach is going to be quite different sometimes. Sometimes it'll be similar, sometimes it'll be different. The difference matters. It's a very important one. And then again, someone who is also experienced working with severe cases of OCD, or where autism is kind of at a higher level, and both, because it sounds like your loved one is dealing with quite severe OCD. And so making sure that someone who has seen cases like that before and has the proper training and experience is really important.
And really the one thing that I would add is really the importance of psychoed, right? And really understanding what is happening and what is occurring and taking it slow through this process.
Absolutely. Okay, next question. My son has scrupulosity. I understand exposure therapy with doorknobs or knives, but it's impossible to prove if there is heaven or hell. We live in a very religious area. My son asks his friends questions and they respond. His OCD is worse the next day. Do we encourage him to not ask questions? How does he expose himself without increasing the OCD? Great question.
Great
Yeah,
question.
Scrupulosity, OCD. Who wants to take that?
I'll start and you guys can follow. But so scrupulosity OCD is one of the subtypes that really involve whether they're religious fears or moral fears around one's faith, around morality. So when we think about exposures, right, and we think about starting with exposures, we're really going to start by what is your child avoiding, right? Are they avoiding maybe spending time with their friends, going to religious services, whatever that might be, right? And can we start reintegrating them into that life? When it comes to kind of your child asking friends questions and all of the above, that's when it becomes a little bit tougher, just because we don't want their friends to feel like they have to be therapists, right? We don't want to have to put that on them to be like, hey, you can't answer these questions anymore. So we really want to make sure that your child is set up with a really good OCD provider that's able to help educate your child as to how these questions are continuing to reinforce the OCD cycle and help them learn different ways that they can reduce those reassurance questions, right? Now, this idea of exposures is going to increase OCD, increase anxiety. It might at the beginning, right? And that's okay, right? Because we really want to get this idea that OCD is not dangerous, anxiety is not dangerous. So whatever we're doing, whatever we're responding to, when like what OCD says to respond to, we don't have to jump in, right? So when it comes to scrupulosity, it's very much similar to all other subtypes of OCD, right? We're still engaging in ERP where we're exposing the individual to this fear, to whatever trigger it was, maybe to their avoidance behaviors, and we're asking them to slowly eliminate those compulsive behaviors. Again, at an appropriate pace, right? We do not need to ask them to eliminate all behaviors at once on day one of treatment, right? And never do another compulsion again, but to slowly eliminate it to build that tolerance in their brain that they can manage this anxiety that the OCD is causing. Do you have anything to add?
Yeah, the only thing I would add is just that you can't also put pressure on yourself to change the whole environment for them to not ever get any reassurance, right? Because in reality, you can kind of create an environment in your home where everybody in the family system is on the same page of I'm not going to give my kiddo the reassurance that they want or need and or feel they need. But when it comes to day-to-day life, we only have so much control over if they're going to seek reassurance from their friends or loved ones. And so that's where giving them the education of really what do we want long-term comes into play and is super important. And so I just say that because I see too many times parents often beating themselves up for they're still getting this reassurance elsewhere. What do we do to change that environment? And you can't, because if it's that environment that you change, they're just going to be able to find that in another environment. It's more about the education that the child is receiving and their buy-in to not ask the question long term.
Yeah, all great points. Just two things I'll add is, you know, it's exposure with response prevention. If your child is doing exposures but not response prevention, then I would expect that their anxiety would increase because exposure without response prevention is just doing OCD. And so, of course, we would expect that it would reinforce itself and get worse. So this is why it's really important to make sure your child's working with a good therapist who's monitoring, okay, when he or she does ERP, are they doing the RP part? Because if they're not, if they're like, and that's where we see people, it's really sad to see when someone's trying really hard and they're doing exposures and then they're like, oh, but I'm getting worse. It's like, yeah, you're working really hard, but not in the right way, not in a way that we would expect that you'd get better because you get better from response prevention, not from exposure, actually. So that's really important. And I could get that if you see your son doing exposures and it looking like he's getting worse, it probably means there's not response prevention. So I would double check with that, check with your therapist on that. The other thing is, scrupulosity, can look different than, fear of knives or fear of germs, right? However, like Victoria said, and this is really important, we talk to a lot of parents about this. OCD is a behavioral process. That process is the same across the board. It doesn't matter the particular subtype, the particular types of triggers. So ERP works just as effectively for scrupulosity as it does for any other type of ERP. Sometimes, that being said, sometimes with scrupulosity, we will involve a religious figure, like a priest or a pastor, or a rabbi, depending on what your faith tradition is, who can sometimes come in and help kind of give their approval or their blessing to treatment. And that is a little bit of a helpful reassurance if it happens once or twice in the process to get more buy-in from your loved one. If they're like, well, my OCD therapist is telling me to do these things, but I'm not sure if I can because of religious reasons. And in our experience, almost always religious leaders, they've encountered scrupulosity before, they know how debilitating it can be, and they're oftentimes more than willing to be a part of the process and kind of give their blessing to the ERP work so that the person feels more inclined to do it with that buy-in. So that's really important. If a religious figure hasn't been involved in the process, but that might help, you can also kind of talk to your son's therapist about that. It could be an option.
Absolutely.
Okay, what is the best way to unwind accommodations when they've been going for a very long time? Great question. Yeah.
Yeah,
Great question.
I would start by saying that I think we can also often get discouraged when we think, well, my kid's been doing this compulsion for so long, or this has been happening for so long, and so they're going to have to be in treatment for so long. And the reality is, the second you start to dive in and approach this differently, your kid, after 3 or 4 sessions of doing this differently, should start to notice a difference, right? And so that is alone buy-in for them to say, oh my goodness, this is working. And so same goes for accommodations. If these accommodations have been going on for a long time, but we slowly start to reduce that accommodation, the really important piece that comes with it is celebrating when they've tolerated more. Meaning, maybe you were asked, or maybe they were asking you 4 or 5 questions, and now we've eliminated to 3 questions a day. Really celebrating that with the kiddo and saying, oh my goodness, 3 weeks ago, this would have been so hard for you to do. And now you're going to school and you're having a great day, and we're only spending time asking 3 questions before bed. Look at how far you've come. And that alone gives them kind of the motivation and the acceleration to continue to reduce those accommodations. And so the approach, regardless of how long the accommodations have been going on, still remains the same. The good news is it doesn't take as long as the accommodations have been going on to see those same results.
Absolutely. And I think the only thing I would add is this is like a prime example of not all accommodations have to be removed at once, right? Is like take it slow, kind of go through the process, make sure y'all are on the same page before you actually start to remove those accommodations.
Yeah, and I think the most important piece, as kind of Callie was alluding to, is you changing your behavior, even if it's very small in the beginning because you've been doing accommodations for a long time or all the time. You're sending a really important message to your loved one, whether that's a child or a spouse, that like, I'm not going to be doing this anymore. Even if I'm just changing one thing, they kind of oftentimes quickly get the message, oh man, I'm going to have to make some changes too because they're serious, right? Especially if you prove that you're serious, even if it's just changing one small thing and you're still doing all the other accommodations, it sends a really powerful message, and it oftentimes is what helps people get in the mindset of like, I have to make a change because the accommodations, I see what direction this is going in, and they're going to be going away. So that's very important. Okay, what is the can you talk a little bit about how OCD can impact intimacy in a marriage, whether it is contamination anxiety or moral scrupulosity? Can this be improved upon, recovered, and what is the approach? How does the partner appropriately participate? Accommodations can be complicated, as are the emotional connections, attachment components that result. This is a great question. I love this question. Who wants to?
I think we should like break it
Break
into,
it, yeah.
yeah.
There's so many pieces to this question.
The first piece is, can you talk a little bit about OCD's impact potentially on intimacy in a marriage?
Start with that.
Sure. Yeah. So we can see that OCD can show up in a lot of different ways, right? When someone is feeling anxious in general, their desire to be intimate probably goes down quite significantly, right? So that alone, just feeling the anxiety from whatever subtype of OCD that they're experiencing, can negatively impact intimacy in a marriage. When someone's struggling with contamination OCD, they can start to all of a sudden have disgust around intimate behaviors with their partner or loved one, and that can lead to some avoidance. When it comes to scrupulosity or moral scrupulosity, they can start to feel like, I don't want to do anything to go against what my partner would want, really getting stuck on these people-pleasing behaviors or pleasing behaviors for their partner that's really just taking away from their ability to be present at all, right? And so we know that it is hard for intimacy to be a part of a marriage if one of the individuals is just not there mentally. And so I think those are some of the ways, especially with scrupulosity or contamination, that we see it come into play. But like I said, it can impact intimacy with all subtypes of OCD. When distress is heightened, intimacy sometimes falls off the table.
The next part would be, can this be improved upon, and what's the approach?
100%, right? And I think this really goes back to ERP, right? And engaging in exposure and response prevention, as well as, and I know the next question is like, how does the partner appropriately participate, right? Involving the partner in treatment, right? If the loved one, of course, is willing to involve the partner in treatment. But I think that's one of the most amazing parts of especially like our program that I love is we incorporate the family therapy piece into treatment, right? So it's not just working with the individual, you're working with the entire family system and being able to educate the partner on what exactly OCD is, right? Educate them on what treatment looks like, right? So what ERP is, and work together to formulate this exposure list, right? where the individual that's living with OCD is kind of stating out like, okay, what are these compulsive behaviors? What are these avoidance behaviors? What are some of these things that I'm doing to try and relieve that anxiety, right? And can we start to slowly break those down and start somewhere, right? And work with the partner, work with the individual with OCD and the partner to slowly remove those accommodations if there are accommodations happening, or help the individual with OCD engage in those exposures together, right? On the same team, being together versus kind of keeping it separate.
Yeah, and I think that one oftentimes crucial part of the family work with OCD, whether it's with kids or with spouses or partners, is in a therapeutic way, being able to share with your loved one the way that their OCD affects you personally, right? Because kind of like Callie and Victoria were talking about earlier, as parents or spouses, we want to protect our loved ones. We have a natural, because we love them, we don't want to see them suffer. We know they're feeling bad already, so we don't want to make them feel worse. But sometimes we are urged to downplay the effect that it has on us doing the accommodations or missing out on intimacy that we really want with our partner because of OCD. Also provides less motivation for the person to change, right? When someone, it's really hard to do to do OCD treatment, to do ERP. Someone has to really have a lot of motivation and willingness to do it. Once they do it, it works great. But oftentimes that's where people struggle, is getting started. If they understand the impact that their behaviors are having or their avoidance is having on their loved ones, not in a shaming and blaming way. We're not putting the blame on people, but we are being honest about the ways that it affects us and the ways it makes us feel as loved ones. That oftentimes will help motivate people to do the work, because they're like, oh my gosh, I'm struggling, but I had no idea how this is making you feel. I had no idea what you're missing out on. And because they love you and they care about you, it adds to their own internal intrinsic motivation to do the work to get better. So being honest with your loved one, again, in a kind, compassionate way, is really important.
Yeah, I only just wanted to touch on the last part of the question too, about how accommodations can be complicated. And I really like that you put that, because I think for whoever is walking through these accommodations and OCD treatment alongside their loved one, it does feel like it's complicated for you, right? When it comes from the outside perspective, though, it doesn't have to be. So I think what I would just try to encourage you to recognize is that if we start to eliminate accommodations, yes, it feels uncomfortable, but it can be a little bit black and white of, okay, my loved one is asking me this many questions about intimacy when we're being intimate. And so our therapist or their therapist has said, you only get 4 questions. And so your job as the partner is to only answer those 4 questions this next time. Or maybe it looks a little bit more like through the course of intimacy, we're only, like, loved one is no longer washing their hands beforehand or changing their behaviors. And so I just point that out to say, I think what we're saying is complicated is the feelings that you're getting associated with just letting your loved ones be distressed. But in regards to building a plan around that, I just want to encourage you, it doesn't have to be super complicated.
Totally. What lifestyle factors like sleep quality, caffeine intake, or physical activity have the biggest impact on preventing OCD flare-ups?
I just want to say that, well, a coffee lover myself, that, and I said it with so much energy, that, when it comes to, like, I've heard so many patients or individuals with OCD say, my OCD gets worse when I drink caffeine, or when I incorporate this thing that I used to love that I can no longer have because I notice that these flare-ups come into play. And in reality, right, like, if we don't get a good night's sleep, our OCD symptoms might get worse. If we don't, if we're in the middle of a really big OCD flare-up and we're just starting treatment for the first time, we might be more sensitive to things like caffeine, noise even, right? And my encouragement would be that you can't just take away, it shouldn't be so all or nothing, right? So, like, I can't avoid noises at all times so that I don't get that startled response. Just like if you loved coffee and coffee has now caused something to, you notice more intrusive thoughts around it, we wouldn't want to take coffee off the table either. It might be something that you do at the start of treatment to build some motivation to do exposures or to even be able to tolerate some of the exposures, but it should never become this black and white thing if it wasn't black and white to begin with.
Yeah, we
Absolutely.
don't really, what's really the most important thing is you don't want to send the message that you're afraid of an OCD flare-up,
Mhm.
right? That, like, if I have caffeine or if I don't get the perfect night's sleep, I'm going to have a flare-up. You might have a flare-up, but that's okay. It's okay to have OCD flare-ups. And in fact, to get better all the way, true freedom from OCD, we have to experience some flare-ups, but we want to face them, not afraid of them, not doing everything we can to prevent them. Actually, we want them to show up. And so, like Kelly said,
Mhm.
I totally see that all the time when people are like stressed, a lot going on, sleep deprived, their anxiety and OCD tends to get exacerbated. But if we're doing treatment and we're doing it the right way, it's okay. In fact,
Mhm.
maybe it's even a good thing. You can see if you're approaching it the right way, you can, oh, I can handle that. I can handle, because we're not going to have a good night's sleep every
Right.
night.
Yep.
That's just not possible, right? And if we get really rigid about, I need to do all these things or else my OCD becomes uncontrollable, we're really undermining a core principle of treatment. So, did you want to add anything?
No, you also perfectly.
All right. We are very new to OCD, like within the last few months. How long do we let the compulsion continue before we step in? Or do we step in at all? For example, my son will spend hours driving in circles to reassure himself he hasn't hit someone or something along the drive. Um, he
30-minute drive.
30 minutes drive can take it. Sometimes 30 minutes drives can take him 2+ hours.
Yeah.
Absolutely. And I think first thing that I'll say is just kudos for you for being here and for learning more, right? At the start of an OCD journey is probably one of the toughest parts, right? Because you really don't understand what's going on, what's happening, right? So just being here and learning more about it is truly amazing. I think there are probably a couple different ways to answer this question. And I'll throw in what I would suggest, and then I'll have Callie and Ryan throw in their opinions as well. But I think ultimately it depends on the age of your child and kind of your relationship with them as well. But it never hurts in moments of low distress, right? I do not recommend having the conversation in high distress moments when your child is in the middle of a compulsive behavior or like really kind of amped up to have this conversation. But at a low level of distress, kind of maybe at a family dinner or whatever it might be, just kind of gently bringing up like, hey, I've noticed that you've kind of been getting stuck driving lately. Like, is there something that I can help with? What's going on, right? Not in a shaming motivation, not in like a, hey, you're doing something wrong way, but more of like, hey, we're concerned and we want to help you, right? Because that can be a really kind of nice gateway to what does treatment look like, and can we tell you a little bit more about what treatment looks like?
Yeah, I would just add, I mean, I agree. There's so many variables that I would want to know, like what's his age, and, just different things that I might approach it a little bit differently given the particular variable in place. But one thing that I will say regardless is there some willingness for you to join one of his sessions, right? Like even going about it with an approach of, hey, if he's in therapy, hopefully for OCD treatment, and if not, make that suggestion to him. There's a gold standard of treatment that works, exposure with response prevention, and you don't have to struggle in this way. And lots of people have OCD, and lots of people can get better from it, and it doesn't have to slow them down anymore. But if you can join one of those sessions, I often tell parents or loved ones, regardless of the age, to approach it with, I would love some tools to help support you in any way that could be helpful or beneficial. Could your therapist give me a little bit of education? And it doesn't have to be you take up the whole session with them. Like, could I join for the first 10 minutes or 15 minutes of the session? And maybe he goes to his next session and pitches that to the therapist so that there's a plan for you to join the following one so that you can give some of your observations, because he might not recognize that this is as big of a problem as it is. And so for that therapist to hear your perspective in it, they can really give you the tools and him the tools to address it more appropriately.
Awesome. What exactly is the response prevention part? Great question. So maybe you guys could talk a little bit more in detail about what is that? Because I do think that that is oftentimes the confusing part for people when they're new. They understand exposure. We can get that pretty easily, but what exactly is response prevention?
So, okay, I'm gonna try and break this down into very simple steps, but it probably won't sound simple, right? But response prevention is ultimately at its core just not doing what OCD is telling you to do, right? So if OCD is telling you to go wash your hands, we're not going to wash our hands. If OCD is telling you to avoid going to that baseball game, or not, we're going to go to that baseball game, right? That's kind of the simplest version of response prevention, but when we really get into like the nitty-gritty of it and what that looks like, is we want to make sure that we are truly addressing like what's at the core of your child loved one's OCD, right? What are they truly afraid of, which is causing the individual to wash their hands or to avoid going to this game or to ask those reassurance questions multiple times, right? So when we look at response prevention, it can be broken up into really ultimately like when an individual is triggered, right? When they're experiencing an OCD episode, what are some of the things that they do and what are some of the things that they don't do in response to that trigger, right? And starting there and being able to say, okay, the things that they do, maybe let's start reducing those, right? If the things that they do are causing less or in an attempt to reduce the distress. And the things that they don't do, are they not doing it because they don't want to feel anxiety? Well, we're going to start doing that.
Yeah, I'll give a case example. So I was early on in my OCD treatment of being a therapist, and I think been a therapist now for 7 years. So this was like year one. And I was working with an adolescent who had struggled with touching doorknobs. And so a big part of the exposure work was getting her to touch doorknobs. And like I said earlier, we usually should start to see some reduction of anxiety if they've practiced that exposure for 3 or 4 sessions, really starting to see that anxiety go down. She came to me at session 3 and she goes, I don't get it. I've done the exposure work 3 sessions in a row now, and I'm still just as anxious when I'm touching doorknobs. And so I started to ask, well, some questions, right? A deeper dive. What are you doing after you touch the doorknobs? Well, I'm just waiting at my desk like this until it's time for me to be able to go to the bathroom because I know you said I could wash my hands after I go to the bathroom. Well, that's a perfect example of engaging exposure work without response prevention, right? So we're not going to see the benefit that we need to do if they're not leaning into that response prevention of, okay, I touched the doorknob and now I need to go forward and cross-contaminate things, right? Because my OCD says, well, you shouldn't touch that backpack now, or you shouldn't touch your bed now. And so cross-contaminating might look like doing those things. And that's really letting the exposure work live on, is how I say, are we engaging in response prevention? Are we letting that exposure work live on? Or are we still avoiding? Her example was just trading one compulsion for another, right? So I'm willing to touch this doorknob. I'm doing that exposure. And maybe she's not washing her hands immediately like she was, but now she's engaging in full-on avoidance of touching anything else, right? And so we're looking, are we just replacing another compulsion with one compulsion with another? Are we actually truly leaning into that exposure and doing the opposite of what OCD wanted? And that is what true response prevention looks like.
I'm curious if you can talk a little bit about like that leaning in piece, right? So I think a lot of times like we get the question of like what does leaning in actually mean and what does that look like, right? So when we lean into the exposure, what does that look like?
Yeah, I would say the simplest way to answer that is, what does leaning out look like, right? So
Yeah.
if she is sitting like this, back waiting, hoping not to touch anything, that is the opposite of leaning in. Leaning in would look like I'm fully diving in and I'm letting myself touch the things that I feel are contaminated. Leaning in might look like, Victoria mentioned that this adolescent is nervous about going to the baseball game, maybe because they're going to see someone that's triggering or they're going to touch some contaminated items. Leaning in would be kind of having this I can do it attitude, right? That this actually doesn't bother me, even though they might feel like it does. We often tell our patients here at OCD Institute in residential, have a so what attitude, right? OCD says you can't do this or this should be really scary. And you're kind of approaching it like, no, it's not. And that's what we mean when we say leaning in.
Yeah, the beautiful explanations and some great examples. I'll give just one more example of like a less um, concrete type of OC. You know, somebody asked earlier about scrupulosity, for example. So especially when compulsions are more mental. So let's say if someone has scrupulosity and they're afraid of doing something sinful, let's say encountering the word devil, saying the word devil, or hearing that, or numbers, 6 or something like that. And usually their compulsion is if they ever hear someone says the word devil or they think the word devil, they then have to say a prayer in their head or ask for forgiveness before they can move on. Or they can't pray again until they feel like they've gotten forgiveness because they don't want to pray to God while they feel tainted or sinful, right? So exposure would be having them say the word devil or think the thought devil or read a Bible passage that mentions the devil or something like that, or watch a show where they talk about devils. That's the exposure. But if the person does the exposure, but then they still ask for forgiveness in their head, or they still say a prayer in their head, or they're still trying to figure out afterwards, did I do that intentionally or not? And does that mean they're ritualizing. And so they're just going to get worse, right? That's just exposure without response prevention. Response prevention means we're exposing them to the thing they're afraid of, but we're not doing our usual response, which is a ritual or a compulsion, right? Even if it's a mental one. So for that person, it would be, I'm going to read a passage from the Bible where the devil's mentioned, and I'm not going to ask for forgiveness. I'm not going to say a prayer. I'm going to read the passage, and then I'm going to, go do something important, like I'm going to go to church, or I'm going to, talk to my friends about, my faith, or I'm going to, go play basketball, and I'm going to go touch everything if they're worried about emotional contamination from the exposure. That's leaning in, that's doing the opposite of what OCD tells them. That's how someone gets better from this. We're almost out of time. I think we answered most of the questions. This is great. You guys did a great job. Really, I feel like I hope you all have a really thorough understanding of what ERP is and what it's not, right? Especially this piece we talked about of exposure without response prevention and how that can keep people stuck. And what your role as a loved one, as a parent or a spouse, or a child, we also see sometimes adult children who they have an older parent who's struggling with OCD, and they can be just as affected. So no matter what your family situation is, we want you to know that we are here for you. We are open to questions and support through the services that we offer. We have a residential program, a day program, and outpatient services. And our passion and our mission is to bring people freedom from OCD, to provide evidence-based gold standard treatment for OCD and anxiety disorders for people suffering from OCD and their loved ones who are affected by it. So please subscribe to our newsletter. You can find us on Instagram. Where else can people find us?
Our website, ocditexas.com.
We hope that you'll continue to join for this family webinar series. We have some really great topics coming up for you. We'll do this once each month.
Awesome.
Absolutely.
Thank
Thank you all for
all.
joining.
So much.
See you next
Bye.
time.